So welcome everyone. Thank you again so much for joining us. My name is Rebecca Bally. I'm a project manager and practice facilitator here at HealthInsight in Oregon. And I would like to welcome you to our LAN Learning and Action Network webinar titled Pharmacist Support for Patients with High Blood Pressure. I do want to give you a heads up that this will be an interactive call where we're going to turn things over to you periodically. We're going to be asking you to interact with us in chat. We have a couple of polls that we'd love for you to answer and respond to, and those should pop up pretty easily on your screen and be pretty self-explanatory. But I also have a few of my colleagues in chat ready to help you out if you have any technical issues or are having trouble seeing anything. There's also a raise your hand feature. If you would like to ask your question verbally, we can unmute you to do that. Although chat tends to be easiest, sometimes folks' microphones aren't connected. Okay, so we're gonna do, and this is where I guess on the screen here is where you can see the chat. We ask that you select all panelists and attendees. That way everyone can see your questions. You might have a question that somebody else also has, so it's nice for other folks to be able to see that. And that should show up at the bottom of your screen or at the top of your screen, depending on which window box you have open. Okay, and the raise hand is there. So for our first test of this technology, we would love for you to chat in sort of where you're located, what kind of a setting you're coming from, the name of your organization, and anything else you'd like to share about your interest in this call. And I believe my colleague Kelly from New Mexico has added a question in there too, and so we'd love to see your chats come in. And while those are coming in, I'm going to introduce our speaker today, which is why you are all here. Dr. Nicole O'Kane is the clinical director at HealthInsight Oregon, where she works with clinicians, administrators, educators, purchasers, community-based organizations, professional associations, and policymakers to improve care across the healthcare delivery systems. She provides clinical and pharmaceutical expertise in the design and measurement of patient-centered initiatives. Dr. O'Kane earned a Bachelor of Science degree in pharmacy from the University of Minnesota and a Doctor of Pharmacy degree from the University of New Mexico. So we are in such great hands, and I am very thrilled to turn things over to Dr. O'Kane.
Thank you, Rebecca, and thank you everyone for joining us today. I appreciate your time as we help you navigate the complex healthcare system and think about ways that pharmacists can help you and your patients in that navigation. A little bit about our learning objectives, and really before I go into any more details, I want to reinforce what Rebecca said initially. We want to be relatively informal. If you've worked with me in the past, you know that I'm a very informal presenter. I want you to get what you need from the call, and your setting might be very different. Your needs might be very different from your colleagues, so it's great to be sharing across chat. The other thing I wanted to let you know about is that this topic has been so exciting, and we've had so many questions and comments about it, that we've decided to cover this topic over 2 months. So our next month's LAN, Learning in Action Network, will continue this topic, and I'm pleased to announce that we'll have some pharmacists working in the field as panelists to further help you weed out and think about ways that your patients can get better access to the great care that pharmacists provide. So, and then along with that panel, today I want to try and provide examples as much as possible for you. So I have one ask during the time that we have today is be thinking about a patient or a group of patients that you know of that really maybe struggle because of their chronic illnesses, because of their complex medication use, or for their lack of access to a coach, if you will, or that a little bit of an extra support around their medications. And any of you that have worked with pharmacists know this is exactly where they fit in. So you be thinking about that patient, and really what our objectives today are around exploring the role of pharmacists, how they look different in different settings, help you differentiate the different kinds of things that a pharmacist might do for you and your patients. A little bit of background about pharmacist-provided services. You're probably familiar with some of them, but there's probably some that you may not be aware of. So we'll talk a little bit at a high level, thinking about different ways in which a pharmacist might help your patients. And then specifically coordination. So pharmacists often get isolated, whether they're in a retail setting or whether they're in a hospital. They might not be integrating as well as what might be ideal. So thinking about ways to strategize to bring that pharmacist to the table. So we did a poll as a pre-registration question, just for me to get a sense about how many of you currently have a pharmacist on staff in your healthcare setting. So whether you work in a clinic or whether you're in a public health setting, whether you're with an insurance payer. And I was pleased and surprised to hear that 2/3 of the registrants had interacted with pharmacists where they were on staff in their setting. So I'm curious of the audience today. Rebecca's going to help us do this poll with technical instructions.
Okay, so you should see a poll pop up on your screen. If it didn't just automatically jump up, it might be a pop up on that bar, the same bar where you found your chat. And just select one of the options presented there and make sure to click submit, and then we will see what the polls look like. We've already got several people answering in. Okay, I'm going to go ahead and close the poll and share the results. There you go.
Okay, so it looks like we have a nice mix, which is mostly what I would expect. And when I speak to large groups and we work with groups that work with pharmacists, it's usually a mix of just this. So in your setting, you maybe don't have a pharmacist on staff, but that doesn't mean that your patients won't be able to access pharmacy services. And we'll talk a little bit more about that. And then for you folks that have a pharmacist on staff, we do want to hear in the discussion a little bit more information about what those pharmacists might be doing, or if you have questions as we go through this topic about other ways that you can draw out that pharmacist. And then finally, I suspect there may be 1 or 2 pharmacists in the audience, so that would be a great way for you to share what that looks like in your setting. So thank you for sharing. It's frustrating to talk into a phone, so it's nice to know you folks are at the other end of the line. So a little bit of background about pharmacists. You may or may not be aware, pharmacists are everywhere. We have traditionally been a more modest professional group. You know, we work hard, we're always there in the background, whether it's in a hospital, whether it's in a long-term care setting, working at a health plan. The pharmacists are everywhere, but people don't always notice that those pharmacists are there servicing their patients and their family and friends. Because again, we traditionally haven't done a great job of shining a light on all the valuable services that we can provide. And thankfully, that's changing. So what setting do you work? Help me to understand the audience a little bit better. Do we have a nice spread across the continuum? Are you in a retail pharmacy setting, a hospital setting, long-term care, a clinic, a health plan, public health, or other? And usually when we do these kinds of polls, as the previous, it's a nice mix across the board, but this will help me to just address or anticipate some of the questions or some of the needs that you might have.
Okay, you guys were quick this time around. You're learning fast. So here you go.
So it looks like the majority in a clinic, and that really is an area where HealthInsight works quite a bit. You know, we provide a lot of innovative services to help with clinic design, redesign. We do a lot of training and technical assistance. And so you probably we provided some of that value for you in the past. We've also have some people from a health plan, which is great. That's an area really that we'll be talking about throughout today, and our panelists next month will be describing how to tap into the health plan services that can be provided for some public health and other settings. Thanks for participating in that poll. A nice mix today. So, you all know, if you work in a healthcare setting, that medications are the most common medical intervention these days. You know, their potential for causing great benefit is always there. We always need to be aware of how far we've come with medications. But what people forget is that they have the potential to cause harm. And so really the area where pharmacists work the best, and this is a quote from the Institute of Medicine, but really that we need to, Americans, all of us need to have a benefit from someone who is very critical around how medications work, that the pharmacist, as I said earlier, be at the table as the medication expert. Coordination across communities. You know, in the past, we were all very siloed. No one had electronic health records to share data across those systems. And we know that those silos did not serve our patients. So, you know, payers have now really been forcing this new model. The public certainly is demanding that we coordinate across these care systems. You know, we try to put patients and families at the center of all the work that we do. We're proud to have a beneficiary and advisory group. And so all the projects I work on, I always get some kind of feedback from patients that are caught up in these complexities of the system. You know, don't forget about the health insurance system. We talked about that. The legal system can also be involved, whether it be related to legislative changes, which certainly has allowed better access to clinical pharmacists. The support systems, this can be everything from community centers where elders gather at lunchtime and a pharmacist, you know, provides some coaching support there. It also is anywhere where people can access outside the healthcare system services. The example that we have at HealthInsight is really the improvement about patients getting access to self-management skills. So going to weekly classes for 4 to 6 weeks to learn about their chronic illness, to learn from peers about what works well. So as you think about your own area, don't forget that there's support systems really across the community, and we should be coordinating and trying to really maximize each of these areas to provide better services for our patients. So where do pharmacy services fit in? You know, our topic today is high blood pressure, but I think you're all aware that a person with high blood pressure that doesn't have any other chronic illnesses, that perhaps is able to control their blood pressure with diet and exercise and perhaps a single medication, probably doesn't need the support of a pharmacist as that coach that I alluded to earlier. But we don't have that many patients in our healthcare system that represent a very simple case of high blood pressure. More of our patients, as you know, have overall cardiovascular disease, you know, so they have cholesterol, high cholesterol that they need to manage. They may have certainly high blood pressure, but they might also have diabetes, which further complicates that. Often folks get into either because if they had a heart attack or heart failure or risk of stroke, they need anticoagulation therapy, warfarin, which has risks associated with it and a real narrow focus for managing it, in which is a great area where pharmacists have really shined. And it really is a good example where a patient doesn't always need a prescriber or a provider in a traditional sense. Sometimes what they really need is a pharmacist who has the specific skills around, for example, anticoagulation therapy. And with the shortage of nurse practitioners and providers, pharmacists have really been able to fill a need here around these complex patients that really need extra help, in which the primary care provider, and in the setting that we're in, it doesn't make the most sense for that patient to keep going back to the primary care provider. They need some special help with those medications. And then don't forget about smoking. Pharmacies provide smoking cessation. They do coaching. A lot of the retail pharmacy programs now are working with health plans to screen people for tobacco use and counseling them around smoking cessation. Of course, anyone that has diabetes and cardiovascular disease has to get their immunizations so that they don't end up in the hospital with influenza. And then, of course, don't forget that pharmacists, people misunderstand that our role is all around medications. It really is around effective treatment. And that treatment might be good diet. We might be reinforcing exercise choices. So every time that a pharmacist interacts with a patient, they're reinforcing those healthy style, healthy choices with patients. A little bit about the role of the pharmacist, and it can be very confusing, and especially in the past, people often thought about that pharmacist as the public-facing pharmacist that we see when we go to our grocery store, or when we go to our Walgreens, we pick up our prescription. That's the pharmacy face that we see, and those folks do much more than dispense medication. They're the last line of defense before that prescription therapy goes out. They're reviewing medication history. They're counseling patients when they have questions. And they are the most accessible healthcare provider in the United States. So that role is essential and important. But distinct and different from that are all the other pharmacy services that can be provided that aren't connected necessarily to a product. And so I call that part of this role monitoring and coordinating. Now, traditionally, a retail pharmacy hasn't always been set up to do that. They haven't always been reimbursed for services to do that. But in that setting now, they are creating more ways to monitor, to coordinate, to work with patients monthly. But as we talk about pharmacy services, try and think about these as somewhat distinct, but also overlapping, which is we want effective treatment and we want safe treatment. And we want to reinforce the therapies that providers are recommending, and we want to communicate back to those providers. So the term has been developed over the last 10+ years that refer to a clinical pharmacist, and that tries to get to this service that is not related to the medication dispensing and counseling. And so that's the term that I'll use to sort of delineate this further expertise. They're seeing patients direct care. They're probably billing for that care. Insurance companies are reimbursing them for the time to work with those patients to optimize therapy. So really the definition of a clinical pharmacist is probably and may not be associated with the product, but that can be overlapping. It might be a little confusing, so let's go into a little bit more detail. There are services that focus on effective medication use. So the best medicines, the right medicines, and not too many medicines that aren't being effective or aren't helpful. They're always part of a care team. They're not isolated. They're communicating back to the providers of that patient, and they're communicating back to patients. This service is in a variety of settings. As I said, it might be in a retail pharmacy. It might be telephonically. It usually is separate from the dispensing roles of pharmacists, just to help delineate this enhanced service. Why is this important? Why are insurance companies paying for these kinds of services? Well, we know an ROI is a return on investment. Is kind of a rough back of the napkin estimate that says, I'm going to spend this amount of money up front, but I'm going to get some value for that money spent, and then calculating, in fact, yeah, when I hire a pharmacist, they not only can help me save resources in my clinic, but they, in addition to, help save hospital admissions, readmissions. They help with quality measures, which can affect incentives. So the Surgeon General, this was 7 years ago, basically did a large report that said, come on, people, we usually ask for a 2-to-1 investment in healthcare, and these folks are providing sometimes a 10-to-1 investment on their services. Why aren't there more clinical pharmacists out there? And this really drove this model that provides the answer that you gave me today, in which a lot of your clinics have pharmacists in them, if not every day, maybe one day a week. So the value is there. So why doesn't everybody have a clinical pharmacist? The values are mostly around complex patients, or in areas where, as I mentioned, there's not you need specialized services, or it's a rural setting, so the access isn't always there to have a provider there. I'm not going to go into a lot of detail, but unfortunately, decades ago, The Social Security Administration wrote in much of the extended legislation around Social Security and reimbursement, they said these are the people that are providers, these are the prescribers, these are the medical care people, and they listed a long list of everybody you can think of. And unfortunately, they didn't list pharmacists. Pharmacists weren't on that list, probably because it was so long ago that so few treatments really included medication that it wasn't, and my profession was not a clinical training at the time. So for all those reasons, we got left behind in the initial models for how physicians get billed for services and how those services get reimbursed. Now that's being corrected, and most states have now given pharmacists a provider status, but this lack of status has been a huge problem for my profession. We don't always get reimbursed, and because we don't get reimbursed, you know, maybe it's hard to justify the service of having that pharmacist on staff. Because there isn't a pharmacist there, no one thinks to include them in the electronic health record. So even now, as pharmacists begin to work in settings outside the clinic, getting access to that electronic health record has allowed them to have a real coordination across the care system. So it's as much as possible when pharmacists are working in a clinic or coordinating with the clinic, we try and make sure that they have access not only to the electronic health record, but other health plan data that might be available, population health data that might be used to, you know, to manage their patients. So I mentioned this a little bit, but these services, they're provided by a clinical pharmacist. They've been well documented and proven. They improve health status, they improve clinical outcomes, they reduce overall costs, primarily through reducing medication problems and also helping, as I said, with those patients that are really have a lot of complex conditions and really have a hard time either because of other medications or other things that are going on. So pharmacists often are a bridge to the other services that a patient might need. For example, a patient with diabetes and heart disease might need access to dietary information that a pharmacist can provide, but a pharmacist can also network to get them back into a diabetes management program, to have them see a dietitian, to get those patients into classes, as I mentioned earlier, the self-management classes. So they become a bridge, and really that's the benefit. There was some work done around the return on an investment nationally, and on average, they save about $1,000 per patient, especially when focused on coordination around admission, readmission. So now it should be that everyone's on board with these services, and to a great extent they have been. They do provide assessment. They can prescribe, and people often don't realize that pharmacists are prescribing. They're prescribing under the authority of a protocol, or they're working with a physician to say, you know, for all my patients with cholesterol challenges, these are the 5 things that we agree that Nicole can do with my patients, and this is what it looks like. And then if there's anything outside that protocol, then you interact again with the medical director or that overarching provider that you work with. It's very similar to a nurse practitioner that works in the clinic. They do, of course, high-risk, high-cost treatments. So a lot of hepatitis C patients have a lot of challenges with those treatments. So having pharmacists help them with managing those side effects. They are often part of a medical quality improvement team in a clinic. So I alluded earlier to reimbursement around quality measures. So pharmacists are often working in a setting to try and manage those folks that are, for example, you're trying to improve your rate of patients who have high blood pressure under control. A pharmacist certainly can help with those patients. And then the last bullet point there, medication therapy management. I'm going to talk a lot more about this next month because we'll have a pharmacist here that does this work. But I am curious if you've heard the term medication therapy management and a little bit of feedback about that. So I believe we have a poll. I think Rebecca's posting it now.
Okay. Yeah, so the question is, are any of your patients receiving medication therapy management services? And it looks like many of you are finding the polls pretty quickly. So we'll just give it a few more seconds. Okay, I'm going to go ahead and close the poll and share the results with you.
Excellent. So it looks like about half or a little more than half said yes, they are aware that their patients are receiving medication therapy management services. A few also said no, and then of course there's always someone in the group that doesn't know. This is probably because the patient might be receiving it, but not telling the provider. So one of the things that I wanted to cover today and that we'll talk about next time is helping patients to share the work that a pharmacist is doing with them, and then conversely making sure that the pharmacist is always sharing back with the clinic when they're interacting with their patient.
And we did have a clarifying question in the chat about whether MTM is different from medication management or med team education.
Oh, that's a good question. So medication therapy management is a specific term that Medicare came up with in working closely with healthcare providers. If you recall a few years back, Medicare expanded the coverage to include medications, which was great because most people who are on Medicare are taking medications. But part of that law required that if a health plan was going to be covering the medications, they also had to cover a service for the patients that were at higher risk. The term that they used was medication therapy management, and they provided specific billing codes. So this would be the first time that pharmacists were billing for this service in a Medicare environment. So the term medication therapy management tends to refer to a service that was defined originally by Medicare. The good news is that service has now expanded outside of Medicare Part D, so that people that are on commercial benefits also can receive those services. Repeat the two terms that you used, Rebecca, in the chat.
So the question was about, oh, and I just lost it. I think medication management or med team education.
So the details might look different, but the service is the same. So the concept of having a pharmacist or other health care professional that manages medications, usually as part of a team, is the spirit of what Medicare was trying to do. The distinction is those medication management or those medication teams that you're referring to, they may or may not be reimbursed, and how your setting decides to justify that work can sometimes look very different. So it might be, if you're working in a FQHC, you have a global budget, and because pharmacists are so great and have such an impressive return on investment, an FQHC can justify that pharmacist in that global budget. If you're working in a commercial office, it might be harder to justify that, especially in the past when there weren't more creative reimbursement models. There was basically that fee for service, and a pharmacist couldn't bill at the same level that a provider could. So the details look different. The concept is the same, getting services for people that have complex medication profiles. So this is what these kinds of services look like. You know, of course, they're collaborating across the system as much as possible, communicating and get that information back to the care team or to be part of that care team. So this really just looks like a very similar provider visit, only it's a pharmacist that's doing it, you know, so it's an ongoing follow-up and monitor. They're often focusing on polypharmacy. They're focusing on medications effectiveness making sure the patient's taking the medication properly. Often, especially with high blood pressure, people really aren't taking the medication the way the doctor prescribed it. A pharmacist care process, the pharmacist has the information in front of them and can say, Mr. Jones, I see that you haven't filled your prescription in 2 months, so let's talk more about why that is. What are your concerns about taking that medicine? So really making sure that they're meeting the patient where they are and helping to monitor and follow up. So this is, I've talked about this a little bit already, but really if you are in a clinic, your setting that accessing might be, one, your internal pharmacist and how to work with them the most effectively, not only on an individual patient when you're having maybe a challenge with an individual patient, but as a population control. So meaning if you know your patients that are struggling with diabetes, you can set up appointments with the pharmacist to bring those patients in specifically to see that pharmacist. In a pharmacy, that might look a little different. In a health plan, that would look a little different, but all of these services overarching are the same. Effective care, making sure the patient is safe, getting the best from their medication, making sure that they are using the medication properly and that they're not having any side effects. And around, the cost savings and those return on investments that I talked about, not only are patients happier, but they're often taking fewer medications. The medications that they're taking are the ones that are working for them. So they're really more bought in to the plan. So that was a very high level overview of a pretty complicated topic. And that was part of the reason that we thought it'd be nice to bring some pharmacists in next month to talk directly about what they do. But for now, we still have a few minutes left, and I'd be interested to hear. There may have been some questions while I was talking, so let's just run through the chat questions and see if we can continue this conversation.
Perfect. Thank you so much again, Dr. O'Kane. This has been really informative, and we've had some great discussion happening in the chat. So not just questions, but actually sharing. So, for example, Megan Field shared that they have clinical pharmacists that they contract with who do their annual wellness visits and chronic care management. And then Danielle Shannon said clinical pharmacist, but employed by a CCO, coordinated care organization here in Oregon. For some of our small provider practices just getting started, having a hard time with the EHR system and being able to set it up properly for billing and referral, hoping to be able to be set up and running by the end of the year. And then other folks were wondering too about tackling EHR barriers. And Kristen England said clinical pharmacists have their own telepharmacy, RX Live, and contract with provider organizations to incorporate clinical pharmacists into the team with remote access to the EHR. And there were a couple of other folks who said, yes, they're doing billing through telemedicine as well. I thought that was kind of interesting.
Excellent. Yes. Especially I mentioned earlier, the rural areas of America are really struggling with lack of providers, but there are pharmacies there, and there are often colleges of medicine and colleges of pharmacy in the urban area that can provide telemedicine. So a lot of my training was in Minnesota, and that's where I grew up. And Minnesota really has pushed this model. And what we get back to again and again is, how does it get reimbursed? How in fact does it make sense for a pharmacist to be able to help that person who lives in a rural setting? And the answer is, one, sometimes it's state legislation, but more times it's really working with a health plan that's motivated, because we know there's a value. We know the health plans are driven to try and elicit that value that their patients are not getting. So every pharmacist that I spoke to around, this topic around reimbursement, they said, you've got to go back to the health plan. You have to, someone in the chat mentioned our coordinated care organizations in Oregon. They service a Medicaid population, and we know that sometimes folks within a Medicaid population have these kinds of complex chronic illnesses, and they also have an ability to be flexible with the way that they reimburse. So in areas where there's a Medicaid population that you're servicing, there on the other end is a Medicaid payer that wants you to help your patients get access. So sometimes it's just a disconnect between, there's a payer on one side that would love for this to be happening, but aren't aware that in your setting, you would love to have a pharmacist, and there just isn't the connection between those two. I think that also is a similar topic around the electronic health record. And the recommendation when I've spoken to folks about challenges with the electronic health record is there's two parts. One is often it's a billing component, and I think next month we'll be able to ask the pharmacists how they might have gotten through those details of billing. But more often than not, again, it's maybe a billing office that is applying old rules when in fact we have a payer who's ready to update those rules for billing. I worked with a pharmacist in Arizona that came up with a similar model that you mentioned, the annual wellness visits, where basically Medicare will pay for a new Medicare person who's just coming on to Medicare to have a welcome to Medicare, or an annual visit, but who to provide those services, who can provide those services. And that's a perfect way for a pharmacist to be involved, to get reimbursed, and really to be in a position to be reimbursed at the same level that a provider would be, and then that frees up that provider to be doing other things. So it's a win-win for the providers and for the clinic.
Great, thank you. And we had a few other folks share sort of how they're tackling the billing issue in the chats, and someone asked if we could share that afterwards, and so I'd be happy to share that chat discussion with the slides. I think one other question that I had was in terms of thinking about ahead for next month and the panelist discussion, what kinds of things do you want folks to take back to their practice that they could be doing or talking to their teams about so that they're prepared with some really good questions?
Yeah, that's a good point. So between now and next month, and so in the next, I would say in the next week, I would ask that you assess the environment where you're working, and if there is a pharmacist in that setting, set up a 15-minute huddle with them to just do a check-in. And say, like, was that a webinar, talked about pharmacy services? I want to make sure that you and I are connecting around what services you have provided. So just understanding the services that they're currently providing. There's not a person in your setting, if there's not a pharmacist that's there in your setting, be thinking about the pharmacists that your patients interact with. And then what I would ask that you do is, if there was one thing that would solve this problem that we've been referring to, if somehow I could get a payer to connect me, that's my problem. My problem is reimbursement. Then we can speak about reimbursement. If the problem is lack of awareness about a service, then we can address that. Is that what you're referring to?
Yeah, that's very helpful. Yeah. Thank you.
And then I think in addition to this, it's a process by which we can connect you back to either national or state efforts that are happening in your area. Because I think that's the third area where it looks a little bit different in northern New Mexico than it does in southern Oregon. And that's, state laws are different, and also the types of pharmacists that are available are different. And then, the third piece that I would have you be thinking about is this telemedicine. Is there any kind of a telemedicine happening in your setting now? And is there a way that a pharmacist might be incorporated into that telemedicine? Because again, depending on your setting, that might be the solution for patients that can otherwise get to the clinic.
Fantastic. Thank you so much, Dr. O'Kane, and thank you everyone who has taken the time out of your afternoon to join us. We've tried to keep these short, about 30 to 45 minutes. We know that your days are full and busy, so we appreciate you making the time. And we would love just to use the last couple of minutes here to ask a few questions of you, and just so we can be sure that we are providing the most valuable webinars and Learning in Action Network events for you. So we have just 5 short questions. First question is sort of just to rate the value of this webinar. So we have in our mind to sort of, are these helpful for you? Should we keep offering them? And then we have a couple of more qualitative questions that we'd love to ask just coming up. So I'll allow a couple more seconds for that, and I know we want to get you out of here quickly. All right, looks like everybody's chimed in. Thank you so much. And then our next couple of questions, if you could just add them in chat, sort of what were the most helpful topics covered in this webinar? What would you suggest to improve this in future webinars? How helpful was this webinar in supporting your understanding of the topic? And what other topics would you like to see covered in future LAN events? And so we'll leave the lines open to allow you to chat those in. I'll also send out a survey afterwards with the slides and everything so we can capture your feedback. And while you're doing that, just a reminder that our next event where we'll have the panelists discussion will be Wednesday, September 19th, and that will be from 12:30 p.m. Mountain Time or 11:30 a.m. Pacific Time. And so again, that's the topic, pharmacy support for patients with high blood pressure, but it'll be part 2 pharmacist panel discussion. So with that, thank you again, everyone, for joining us today, and thank you again so much, Dr. O'Kane, for that wonderful presentation. We really appreciate it.
Thanks, everybody.